Hello, welcome to this program on Parkinson's disease. I'm Werner Poewe. I'm a clinical neurologist and a professor of neurology at the Department of Neurology of Innsbruck Medical University in Austria. I would like to share with you in this program some deliberations, some thoughts around the issues related to diagnosing and managing levodopa response fluctuations in Parkinson's disease. Levodopa is, of course, still the most important drug to treat the most motor symptoms of Parkinson's disease. However, its chronic use is associated with the development of motor fluctuations, by which we mean alternating periods where patients experience good to near perfect control of their symptoms, with other time periods where symptoms reoccur, be it tremor, stiffness, slowness. And these fluctuations reflect the pharmacokinetics of the drug to some extent. Levodopa has a short half-life of only around 90 minutes. Initially, these plasma level swings that are typical of levodopa dosing will be buffered through synaptic storage of dopamine that has been formed from the exogenously delivered levodopa. Parkinson patients in their early stages have sufficient remaining nigrostriatal dopamine nerve terminals to take up levodopa, metabolize it, convert it to dopamine, store it, and synaptically release it. And as the disease progresses, this buffering capacity diminishes, and therefore plasma level swings are reflected by brain level swings. And that's when these fluctuations become apparent. Another contributor also to the development of motor fluctuations is variability in gastrointestinal absorption. Levodopa cannot be absorbed from the stomach. It has to be transported to the duodenum or proximal jejunum in order to cross the gut mucosa and reach the systemic circulation. And this process is subject to a number of problems related to delayed gastric emptying, which can be a reflection of the gastrointestinal motility problems of the disease. It can be a consequence of food, and is another contributor to the development of swings in motor response. And depending on which mechanism is operative, there are different types of motor fluctuations that we see in the clinic. The classical and most common manifestation, wearing off, is largely a reflection of the short half-life and the loss of central buffering capacity. While phenomena like delayed on after intake of a pill, or even complete failure of a dose to work, are likely related to gastrointestinal absorption problems. And a variety of the wearing off species of motor fluctuations is what has been called the early morning off, when patients after the drug-free interval of the night will wake up in a poor mobility condition. And finally, some patients report on seemingly inexplicable losses of motor control in the middle of their interdose period, something that has been termed paroxysmal on-off by some authors, and is probably a reflection of central pharmacodynamic changes. Motor fluctuations have a significant impact on the quality of life of people with Parkinson's disease, and that is because the recurring signs of Parkinsonism that are typical for wearing off, the most common type of motor fluctuations, they do include motor phenomena like recurring slowness, bradykinesia, rigidity, which can even be painful, tremor, but they also often entail a variety of non-motor experiences that accompany the off periods, and those may be painful, cramping. This may be a feeling of anxiety or even depression or fatigue and apathy, and the combination of both these elements, motor and non-motor, make motor fluctuations so troublesome and unpleasant for those affected by them. This being so, of course, a major consideration when initiating therapy in any patient with Parkinson's disease is to try and, as much as possible, prevent the development of these motor oscillations or fluctuations in motor response. And there are alternative treatments that are useful in those with early and mild disease, for example, MAO-B inhibitors, but of course their effect size is rather small and they're usually not able to maintain symptomatic control for longer periods. Dopamine agonists are another alternative to use in initiating treatment. They are more powerful in their effect size compared to MAO-B inhibitors, but they're also less well tolerated and they have a particular risk to induce unpleasant and potentially dangerous phenomena like daytime somnolence or even sleep attacks or impulse control disorders, including hypersexuality, compulsive shopping, binge eating, as examples. So levodopa, in the end, remains the most powerful of all agents we have, and ultimately, practically all patients with Parkinson's disease will require levodopa. When considering the components that determine the clinical response to levodopa, motor fluctuations have sometimes been called reflective of what investigators in the 1970s called the short duration response. This was at a time when the term wearing off wasn't established as it is now. And this short duration response equates what we now call the wearing off phenomenon. It is very closely linked to the pharmacokinetics of levodopa. It's a short-term phenomenon reflecting the peaks and troughs in blood levels, and it occurs in the context of motor complications that often include both fluctuating motor response and drug-induced involuntary movements, dyskinesias. But there is another interesting element in the time course of clinical changes in response to levodopa, and this has been termed the long duration response. And this has become apparent and visible only in situations where patients on levodopa for extended periods of time were discontinued for various reasons. And while the effect of wearing off and loss of response of the response component we call short duration response becomes apparent within hours, there is a subsequent period which may last up to weeks when patients will still have some residual effect of the drug, which becomes then visible after extended periods of up to weeks when they will experience another degree of worsening, and that has been termed the long duration response to levodopa. The major occurrence of this long duration response effect of levodopa is really in the context, or has been in the context of clinical trials that had used washout designs. A particularly famous example is the levodopa trial, which was initiated in order to test if or not levodopa as initial monotherapy might, while being symptomatically effective, even in a negative fashion, accelerate the underlying progression of disease. This was the idea behind the levodopa trial, and it used a washout phase of weeks to then compare the evolution of disability in that washout period between a placebo-treated arm and a group of patients who had been initiated on different doses of levodopa. And it was interesting to see that after weeks of washout, in those who had received levodopa, their motor status remained superior, remained improved over those that had been given placebo. And this is a very nice example of what we call the long duration response. Now, for the clinician, however, what matters in everyday practice is, of course, the short duration component of levodopa response and the phenomenon of motor fluctuations that is reflective of this. And since practically all patients with Parkinson's disease will, in the end, require levodopa therapy, most of them will be troubled by motor fluctuations at some point in time, and we clinicians need to manage those. And there are different ways of doing this. One way is where we would adjunct other therapies on top of levodopa to smooth out the plasma level swings and the motor response swings. And this can be achieved by adding dopamine agonists, because they do have a longer half-life than levodopa, and they can therefore cover the troughs in levodopa levels to some extent, or to adjunct enzyme inhibitors that will alter the peripheral or even central pharmacokinetics of the drug. MAO-B inhibitors, inhibitors of the enzyme monoamine oxidase B type, for example, act by prolonging the availability of dopamine that has been formed from exogenous sources in the synaptic cleft by inhibiting this enzyme, which is localized in glial cells and is a major component of the breakdown of dopamine once it has been released into the synaptic cleft. COMT inhibitors are enzyme inhibitors that block the most important degrading enzyme of levodopa in the periphery. Current levodopa preparations are combinations of levodopa and an inhibitor of decarboxylase, making sure that there will be no dopamine formed in the periphery. But in the presence of a decarboxylase inhibitor, most of the levodopa our patients take will be metabolized in the periphery, in the liver mainly, by this enzyme COMT. And blocking that enzyme will then lead to a significant prolongation of the half-life of levodopa, and again, therefore, can smooth out motor fluctuation when given as an adjunct therapy. When adjuncting these treatments, one has, of course, to be aware of their potential side effects, in particular in relation to dopamine agonists, which, as I said earlier, are unfortunately capable of inducing impulse control disorders, which can be very problematic for those that develop them. Talking about adjunct therapies using enzyme inhibitors, those drugs that inhibit the activity of MAO-B are easy to use. There are two in particular that have been shown by carefully conducted randomized controlled trials to be able to reduce motor fluctuations and to increase on time and reduce off time. One is resagilin, which is a selective and irreversible inhibitor drug of MAO-B. The other is safinamide, reversible inhibitor of the same enzyme that has another component of efficacy, which is non-dopaminergic, and which I will not go into now. Both went through randomized clinical trial programs establishing their efficacy in terms of reducing off time in patients with fluctuating Parkinson's disease. And we're now talking about a magnitude and effect size in the order of an hour or slightly less increase in on time, which may sound not very dramatic, but clinically speaking, in practical terms, is very, very useful for affected patients. The other class of enzyme inhibitors we use as adjuncts to levodopa to control motor fluctuations are inhibitors of COMT. And there are three that are currently on the market globally. The first one actually that was introduced was tolcapone. And tolcapone had a significant effect on levodopa half-life in terms of prolongation and in terms of reduction of clinical fluctuations and in terms of increasing on time. However, it turned out to be severely hepatotoxic in individual cases and has since become a second-line drug only to be used when other options fail. And until recently, the first choice for COMT inhibition in levodopa patients, treated patients with response fluctuations, was the COMT inhibitor entacapone. More recently, a novel third-generation COMT inhibitor has become available and is being marketed in several European countries and also outside Europe, and this is opicapone. Opicapone seems to have a number of advantages over entacapone. One is that in clinical trial programs and in its marketing phase, it has not been associated with diarrhea. Diarrhea being an unpleasant potential side effect of inhibitors like tolcapone or entacapone, affecting up to 5% to a degree that one can actually no longer give these drugs and has to discontinue treatment because of diarrhea. Entacapone was also notorious to many patients because of the urine discoloration it produces. It's harmless, of course, but a nuisance because it's able to produce stains that are difficult to remove. And opicapone doesn't have that problem either. And there is an important observation from the clinical trial programs with opicapone, and that is related to the effect size, the actual prolongation of on time compared to entacapone, which was tested in one of the pivotal trials with opicapone, is longer. It just failed statistical significance in that particular trial. It was in the order of 20 minutes, just not statistically significant, but patients, when asked to judge their degree of global improvement, they rated opicapone higher than they did entacapone. So there is an indication of a larger effect size of that novel COMT inhibitor. Of course, it would be nice if one was able to somehow overcome the pharmacokinetic reasons behind levodopa response oscillations, i.e. fluctuating plasma levels. And this is being tried and has been tried for a long time already by developing novel levodopa formulations, either extended release formulations that would release the drug over longer time periods and therefore cover larger periods of the day with less swings in plasma levels, and also in terms of more recently developing rapidly acting formulations that patients who have motor fluctuations could use to quickly interrupt an intervening of periods. And one particular novel way of delivering levodopa for that particular on-demand purpose is an inhalable pulmonary delivery system of levodopa that has recently been marketed in the United States, not yet available in Europe. And unfortunately, this availability being restricted to the US, not extending into the European Union yet, also applies to novel extended release formulations of levodopa. Of course, when one tries to smooth out plasma levels of levodopa to produce a more constant response, the best option would be to deliver levodopa continuously. And this is possible and is clinical practice using a jejunal delivery system where via a PEG system and an externally carried pump, cellulose gel of levodopa is being given. This duodopa formulation is in clinical use and has been shown to produce not only stable plasma levels of levodopa, but to prolong on-time, reduce off-time, and even in patients who had dyskinesias as part of their problem to reduce those as well. Of course, giving levodopa through a PEG tube into the jejunum is an invasive procedure, and the pump needed for that is not small. So there are ongoing attempts to improve that continuous delivery arena by developing formulations that could be given subcutaneously. There are several clinical programs in active development of different formulations of levodopa, liquid solutions of levodopa itself or prodrugs of levodopa that are amenable to subcutaneous delivery. And probably the furthest advanced formulation is called ND0612, which has passed a phase 2 program with encouraging results in terms of on-time prolongation and has just entered a large phase 3 clinical trial. The issues one wants to address with these approaches of improving the delivery of levodopa, of course, is to not only treat motor fluctuations, but to even prevent them from the moment go, and thereby improving and somehow the progression of disability in Parkinson's disease. And if we want to meet the goal, the ultimate goal of treatment of Parkinson's disease, which is to maintain quality of life, not only early on, but into the advancing stages and even late stages of Parkinson's disease, we will definitely need novel approaches to, in a better way, deliver our most potent weapon in terms of controlling motor systems, i.e. levodopa. We will very much need treatments that attack both the motor and the non-motor problems, and probably we will also have to be more successful in developing drugs that would target the many non-dopaminergic abnormalities that are present in the brain circuitry in Parkinson's disease. And not to be forgotten, there is a need to design the treatment of advanced Parkinson's disease in a multidisciplinary fashion, and to have a team not only of doctors but of physiotherapists, speech therapists, of social workers, neuropsychologists, to deliver the optimal care possible to our patients. I hope that you could take away some insights on how motor fluctuations develop, what their underlying mechanisms are, and how we can treat them with our current armamentarium, and what is potentially on the horizon in terms of new developments in drug delivery of levodopa. Thank you for your interest and participation.